The purpose is to put forth a profile that defines advanced heart failure. And if you can please advance the slide to next. Now here are my disclosures, and I have served as a consultant for St. Jude Medical, former Thoratec in the context of the device, same thing as an advisor for Medtronic, who really took over hardware, and that's related to the HVAD, and I've served as a consultant for McKay in terms of balloon pump, served as a speaker bureau for Novartis and Amgen. Next slide. Now, my aim is really to focus in on ambulatory heart failure. And I'd like to define a profile that equates to being at high risk for adverse cardiac events with continued medical therapy that supports consideration, at least in terms of referral, consideration for either LVAD use in appropriate patient or transplant listing as it relates to weighing projected benefits and risks. And certainly by doing so, define a profile that triggers consideration for a more formal evaluation. Now we, like many advanced heart failure programs, see a number of patients, over 400 referred. We typically formally present close to 225, and our goals are simple. It's to understand who truly has end-stage heart failure, apply our institutional criteria and biases with regards to how to best to proceed in terms of listing or for VAD, and in appropriate patients that are very high risk, palliative care and support. Now, if you take a step back, there are several assessment domains. Importantly, quality of life and goals of care as it relates to the patient and the patient's family. We talked a little bit about hemodynamics, imaging. I'm going to mention one mortality model, Seattle heart failure model. But we use laboratory and clinical factors to understand the trajectory in this patient population. Now, we talked earlier today about the epidemic of heart failure, and we certainly are familiar with the AHA-ACC stages introduced in 2001, much like in reference to cancer models, highlighting the progression, defining end stages, those that are refractory to medical management in terms of those having persistent high-grade symptoms. The INTERMACS profiles, which were also referenced, were introduced in 2009 to best understand appropriate timing and decision-making in terms of devices. But really the common denominator and what we all use is the New York Heart Class system assessment, and where those with shortness of breath, at rest, or with minimal exertion qualify as high-grade symptoms. What is easy, as we reviewed, are those that are in the unit on multiple pressors. If you're considering going down the shock algorithm, this is easy in the context of prognosticating. I think similarly, when looking at those that are formally deemed to be inotrope dependent, I think those patients are similarly as easy to define. Can you please go to the next slide? And really what is still holds true is that those patients that are in more overt shock, these aren't the patients that are good candidates for heart transplant or LVAD. Next slide, please. Next slide. And so as we're transitioning in the future for consideration for device or appropriate listing in terms of those that are less sick, we know decision-making is going to be beyond survival alone. But as it stands today, those patients that are truly inotrope dependent, and if you go back to the rematch trial, those with severely depressed EF, high-grade symptoms, you put them on an inotrope and they get better. You take them off and do it twice, and they revert to that end organ dysfunction, either by exam or by labs. These patients have a poor prognosis. And so the line in the sand for many, if you will, are those patients that are INTERMACS 3 or worse. But certainly there are a cohort of patients that have more advanced heart failure, but are at home, or these are the types of patients we're seeing in clinic. So what I want to review are two observational registries, if you will, one being a trial, one being a registry. The first being MEDAMACS, which was based on 10 hospitals. It's the medical arm of INTERMACS to understand these trajectories, to assess survival function, quality of life, and eventual consideration for VAD or ambulatory for VAD decision-making, with understanding that these aren't patients that are inotrope dependent. They either have INTERMACS 4 rest symptoms or exertional intolerant, INTERMACS 5 to 6, or less symptoms but have stage C advanced disease. Now, the inclusion criteria is key to put in perspective, and we're going to review roadmap, and we're going to review the guideline documents that define advanced heart failure. Those with New York Heart Class 3 to 4, LVEF less than 25%. We've talked about hospitalizations, and that was part of the criteria in terms of being a red flag. Cardiopulmonary exercise testing, in addition to 6-minute walk testing, is readily used to help prognosticate. And just for those less familiar with this, symptom-limited graded exercise tests on a treadmill or bike, we can measure oxygen saturation, expired oxygen, carbon dioxide, and calculate peak oxygen consumption. And we're very familiar with this data, which is certainly not new, but still holds true. Those with a poor peak VO2, if on maximum tolerated beta blockers less than 12, is associated with a poor prognosis. I think even more simple is the 6-minute walk test. And there is a body of data in terms of the 6-minute walk test with a cutoff less than 300 meters being a surrogate for poorer prognosis when you look at combined death or hospital admission for cardiac transplant, to refer to one particular study. But the 6-minute walk test is readily being utilized and is used both in MEDAMACS as it is in roadmap. And so high-risk feature for these MEDAMACS patients, either 2 heart failure hospitalizations, and Dr. Drasner went over the hospitalization burden that identifies advanced disease, and so 2 hospitalizations or 1 hospitalization with another high-risk feature like a peak VO2 in men less than 16 or a 6-minute walk distance less than 30 meters was considered high risk. In MEDAMACS, they also looked at the Seattle heart failure model. And just to describe this for those less familiar with it, it was derived from the PRAISE trial, over 1,000 patients, subsequently validated in 5 additional cohorts of heart failure patients. And you can easily go online and plug in to the model important parameters that are associated with prognosis related to age, ejection fraction, what medicines they are on. There's been one good investigation about its role in ambulatory outpatients that have heart failure, if you will, and certainly those with a higher Seattle heart failure score have a poorer event-free survival related to LVAD, urgent transplant, or death. We've looked at this similarly in non-inotropic patients in our own experience, and the area under the curve was 0.82, but again, a composite of death, urgent LVAD, or transplant. So going back to MEDAMACS, in terms of those that had an event versus not, event being defined as freedom from transplant, mechanical support, or death, no difference in ejection fraction. In fact, hospitalization burden was common in both, but it was really those with the simple assessment of rest, shortness of breath, INTERMACS 4, being a greater percentage than those that had an event, and those with a higher Seattle heart failure risk score. And when you look at the event-free survival curve, 1/3 experienced an event at 6 months, 44 experienced an event at 12 months, nearly half being death. And so the event-free survival around 56%. Among those 10 centers, again, an advanced heart failure profile defined as high-grade symptoms, frequent hospitalizations, and a higher Seattle heart failure model. But when you look at rest breathlessness in and of itself, the event-free survival is very, very low, only 28%. And looking at it by Seattle heart failure category, and those with the score greater than 2.5, dismal event-free survival under 20% at 12 months. I think we're positioned to learn more about what patients are telling us in terms of prognosticating. And we commonly use the EQ5D, where patients can look at the scale, 100 being best imaginable health status, 0 being worse. And when you do the 6-month survival stratification, pilot data, this was presented by Dr. Teuteberg, ICHLT a few years back, but those with a EQ index greater than 0.71 compared to less than 0.71 was associated with a difference in survival. Now, there's only been there's been 2 MEDAMACS publications, and we are too learning about the importance of not only the patient profile, but their social network. And I think our coordinators would find this very intriguing data in terms of what a lot of time we spend understanding patient support, caregiver support. So the hypothesis was that there may be differences in clinical characteristics and outcomes for patients with advanced heart failure based on their perceived candidacy for transplant or destination therapy. And we all certainly can appreciate there can be a host of reasons why patients have contraindications for transplant or LVAD for that matter, and I've included a number here. Now, looking at those that were deemed transplant and destination therapy VAD ineligible, they did have several traditional markers for greater underlying severity. Serum creatinine was higher, N-terminal proBNP was higher, hemoglobin was lower. Interestingly, their 6-minute walk distance in meters, remember again, less than 300 meters is a red flag. In that particular cohort, 176 compared to 255, for example, the transplant eligible group, and their wedge was higher. And when you look at the survival, this is not event-free survival, but survival, in those that were deemed ineligible, 23% mortality, average follow-up of 10 months. So for me, this is fascinating data, if you will, in the context of just understanding their candidacy. It really points to wanting to understand really the whole breadth of that patient profile to best prognosticate. Now I'm going to transition to the roadmap study, which was a small observational study, several limitations which we'll go over. It was originally designed to be a randomized trial in terms of device versus medical management. This was put forth by Joe Rogers out of Duke and Randall Starling from the Cleveland Clinic. That subsequently, supported by the NIH, was really championed by the Michigan group, and they looked at the HVAD device as the original device. And so this became an observational trial to best understand, in my mind, trajectories in these advanced heart failure patients, where we're trying to make decisions for those that have contraindications to transplant, how patients are doing on medical management, and how they're doing with VAD. So again, perspective, importantly, non-randomized. I'm going to go over the inclusion criteria, but the primary objective was to understand effectiveness of LVAD and medical management in ambulatory New York Heart Class 3B4, so high-grade shortness of breath at rest or minimal exertion, not inotrope dependent, and just to remind the group of the FDA indication for a HeartMate 2 therapy, ejection fraction less than 25%, and again, I think a real criticism here could be what was their optimal medical management, but as deemed by the 41 centers on medical management, but not listed for transplant. Again, this surrogate for a higher risk profile, 6-minute walk distance less than 300 meters, and at least one hospitalization. And when you look at the baseline characteristics, really by what's listed here, no difference. Again, another limitation we didn't tease out on the front end, specifics related to gold dose ACE used or gold dose beta blocker used and the details why, all which would be very, very important to understand what truly is optimal medical management, but no difference between LVAD and OMM, at least those two cohorts. Again, 41 trials. But those that received in that LVAD were a sicker patient population. Greater percentage had shortness of breath at rest, 52% versus 25%. They were categorized as being INTERMACS 4. Patients in the LVAD group had a poorer quality of life by the EQ5D. We used a depression screen, PHQ-9. They had greater severity of depression. And very intriguing that those patients working with their physicians at those centers agreeing on watchful waiting and pursuing medical management, roughly half were moderate to extremely satisfied with their quality of life. And that makes sense. Whereas those that had received a VAD were not, or only slightly satisfied. And I'm going to go over the intent to treat survival and the Kaplan-Meier curve, but instead of focusing in on the direct comparisons, when you look at that profile of those patients that received optimal medical management and look at event-free survival, freedom from death, delayed LVAD, or urgent transplant, just 41% at 24 months. I should highlight that no difference in intent to treat, and really the indifference that drove the primary endpoint in terms of being alive on original therapy and an improvement in walk distance was with the use of delayed LVAD. We did some post hoc analysis really for hypothesis-generating observations in terms of quality of life in those that wanted and agreed to VAD versus medical management. But what we do appreciate and highlight that adverse events related to device support are real. And there were more adverse events when we defined a composite rate in those that received an LVAD compared to medical management. I'd like to put forth two observations for this advanced ambulatory heart failure patient population. We saw no differences in those that were categorized as INTERMACS 5, 6, and 7. It was really driven only in those that had rest breathlessness. And we too are very intrigued about patient perception in terms of risk stratifying. And we looked at above and below the median. And Joseph Stellick presented this, and this is going to be published in Circulation Heart Failure. But those patients that had a worse quality of life, by their self-reporting, actually had a lower event-free survival. And we saw no differences when it was greater than the median. So intriguing data. Again, non-randomized, hypothesis-generating, lack of details with regards to optimal medical management. But the purpose of roadmap, not the purpose, but the real strength of roadmap, it allows us to at least focus in on what are the risks with proceeding with VAD, understanding the risks of continuing with medical management, and really focusing in on those patients that are very, very unhappy with their baseline quality of life. And so the roadmap positions us better than before to have those conversations. So taking a step back in terms of the profile in MEDAMACS, which I would highlight is associated with a high event-free or compromised event-free survival, and a roadmap, very poor ejection fraction, heart failure hospitalization burden, limited functional capacity, 6-minute walk distance less than 300, and patients that are coming in that are very unhappy with the quality of life. Garrick Stewart, looking at the MEDAMACS, asking an intriguing question on whether patients would want an LVAD. I would argue that they don't know enough about LVAD to even know if they want an LVAD, but a fair percentage at least want something different. It may be better medicines, but at least in the context of the hope of something different related to VAD, intriguing. And when you look at specifically those with INTERMACS 4, that enthusiasm for something different, perhaps captured here as consideration for LVAD, was even greater. And so, again, I think that both roadmap and MEDAMACS are giving us good information to carry on those discussions with patients about the realities of risks, about the perceptions of potential challenges, and there are differences. And so there's a lot to be improved upon in terms of decision making. And we're very proud of this was a PCORI grant, multi-center initiative to help understand decision making. And we too know that palliative care for many patients is the right decision, but we talk about the trajectories as best one can estimate, benefit of VAD versus transplant, and most important, very important, I should highlight, is we bring the caregiver into the equation. And it's really only being in the center that offers that time with social work, palliative care, ethics consultation readily available, where we can understand whether one's even a potential candidate. And so Courtney Bruth, who's our ethicist, that's part of our medical review board, we looked at our own LVAD cohort and identified caregiver characteristics that are associated with less mortality. And so a caregiver that understands severity illness, has a backup system, able to provide some logistic support. And you look at the specific patient in terms of living alone, you can see the hazard ratio. So I think we're learning a lot to be better positioned to have these conversations, and the earlier we're seeing these patients, they're better. Now, the American College of Cardiology does have that list, and Dr. Drasner referenced this in terms of not being able to tolerate the same dose of medicines, progressive renal dysfunction, 2 hospitalizations we've mentioned, high-dose diuretic. So this is a checklist that can be easily referenced, the INTERMACS profiles we've reviewed. But when you take a step back and look at the ACC-AHA, the Heart Failure Society of America, the European guidelines, the 4 common denominators, severe symptoms, hospitalization frequency, optimal therapy, we can argue about what that means, and severe functional capacity impairment, I think are the ones you want to be attentive to. Now, I was talking to Dr. Packer about this, because I love this commentary as it relates to the heart failure's dark secret, and I think it's not dark at all. It's shedding light on what's real. There's this thought about focus in terms of device or transplant, and when I reflect on the number of patients that are at our center that are being evaluated and the optimal medical management we're pursuing in terms of diuretics, gold dose beta blockers used in clinical trials, the use of appropriate mineralocorticoid antagonism, those that are appropriate candidates for sacubitril, valsartan, I think this is real. And this really serves as a reminder to all that these indications for referral are for those that are failing optimal medical management, or to be quite frank, those that need guidance on what is optimal medical management, but those that have high symptoms, reporting poor quality of life, frequent hospitalizations, despite trying as hard as you can, really is a patient that's not going to do well. So we see this as an opportunity in terms of considering optimization, looking at these advanced heart failure triggers to work with the community that defines our referral network to best help our patients. And for many, it's continued medicines, and they're a little early. For some, it's palliative care. But for that, although just 1%, for some, it's transplant and LVAD. So at the center of this is the patient perspective and their goals, and this takes a lot of work, and the team here certainly can attest to that. And we're incorporating this in our heart failure disease management to understand optimal medical care, patient expectations, and I think we're moving in the right direction in that regard. So in conclusion, patients with advanced heart failure, keeping it simple, high-grade symptoms, frequent hospitalizations, compromised functional capacity, 6-minute walk test is easy to acquire, shared decision-making and understanding patient expectations and how they feel is key, and I think this positions one to consider earlier referral so we can work together to help these patients. So with that, I thank you for your attention. I'm happy to answer any questions related to this talk. We have an exciting talk coming up soon. Thank you.